So, but I do apologize if some folk I already heard about this story. So I will, as a T cell person, I would want to know like how the T cell react in different disease, especially in hepatitis B and HBV-associated liver disease. But I hope at the end of the story that I will tell you that T cell might not be always beneficial in some cases. So thanks, Anthony. I don't need to go through all the background, but I just want to highlight some few points using this figure from the review written by Antonio and other people. So the T cell and B cell response targeting HBV is very, very complicated, and they are very multifactorial across different clinical stage in patients. But one of the major issues is majority of the data that gathered by many people through the past decades are isolated T cell from the blood. But this is problematic as it's highlighted by this biomathematic paper, which they estimate the number of immune cells you can isolate from blood versus different organ. So the first thing you see, easy you can see is that blood have very few number of immune cells compared to liver, bone marrow, lymphoid organ, lung, skin, etc., etc. And the second thing is the composition of immune cell is very different from liver and blood. This is especially important as HBV can only infect liver. And one of the major phenomena in chronic HBV infections is there's a very different stage of liver inflammation. So when you infected with liver chronic HBV, you can start having some inflammations and eventually progress to have some fibrosis, cirrhosis, eventually move to HCC, the liver cancer. But there is a very rare event that's coming from heavily fibrotic and cirrhotic liver is there's a chronic liver failure or acute-on-chronic liver failure patients. It's a very serious clinical event that is not very well defined based on the immunological data. So based on EASL guideline, acute-on-chronic liver failure in the background of HBV is defined by acutely decompensated cirrhotic liver and carries by high short-term mortality rate. And without liver transplantations, patients with acute-on-chronic liver failure can die, 80% to 90% can die within a month. And previous data also show that there's a systematic inflammations such as TNF-alpha, and you can higher white blood cell count and interleukin A. But however, there's not many data to contribute to the understanding of this disease. There's a few anecdotal example. One paper showed that they isolate the T cell from the blood, but not the liver, in full acute-on-chronic liver failure patient, and they showed that the HBV-specific T cell expanded. And Farsi School also have two papers showing that there's a expanded IgM expressing B cell accumulating in the liver of acute liver failure patient, but they only have 2 patients, and they conclude that the T cell was not involved. So we want to understand is if this is true, especially in the liver. So we recruit 6 patients that have 3 of them are HBV acute-on-chronic liver failure, and the other 3 HBV chronic liver failure patients in Singapore. And this 6 patients took us 7 years to collect them. And ever since I moved back to Taiwan for the 2.5 years, because there's so many cases in Taiwan, so we're able to collect 4 additional acute-on-chronic liver failure also in the chronic HBV backgrounds. And we also include 1 patient that previous HBV infected, but later cleared the virus because of the antiviral drug, but later this person have an alcohol-induced liver failures. So we take the explant of the liver and pair blood and using FACS to sort CD19 and positive and CD19 negative fractions. And we to firstly look at the clinical score of those patients. So the red one is acute-on-chronic liver failure, the yellow one is a chronic liver failure, and the black dot one is an alcohol-induced liver failure. You see there's some elevations of the clinical score in acute-on-chronic liver failure, but overall there are not much differences. And I also want to highlight the 3 patients, due to various reasons, they did not receive antiviral drug. And so we use our the previous technology we developed in Evan Newell's lab. So we base on their HLA type. So all the patients have at least one allele against A1101, A2402, or AL201. And we compose a peptide-MHC library, about 114 different peptide-MHC tetramer, including all the major HBV epitope and some bicenter virus epitope. And we use mass cytometry to multiplex them, and together in conjunction with lots of different surface marker, and everything is read by mass cytometry. So we pull all the tetramer to do into one single cocktail and stain in one single clinical samples. So the first thing we look at is the frequency of all the detection that we probe. So you can see that we didn't detect any surface HBV-specific T cell, but we detect lots of core and polymerase, and also some X protein, and also lots of EBV, CMV, and flu-specific T cell. And if you zoom in to the hit we detected, so you can see most of the detected hit will accumulate in the acute-on-chronic liver failure patients, both in the liver and blood. So this is just a representing plot showing you the quality of our staining, that you can simultaneously detect the HBV-specific T cell, EBV-specific T cell, and flu in both liver and PBMC. But if you look at the frequency, we see there's a large expansions of HBV core and polymerase-specific T cell in the liver, but not in the blood, in the acute-on-chronic liver failure patients, and also very minimum in chronic liver failure patient, and also alcohol-induced liver failure patients. And again, we detect lots of bicenter-specific T cells here. And interesting, we detect HBV-X-specific T cell, but there's not much difference between acute-on-chronic liver failure and chronic liver failure patients, both in the liver and the blood. So we pull all the CD8 T cell and analyze their phenotypic differences. So what you're looking here is combine of all CD8 T cell. So if you can just focus on these two clusters, which is co-expressing CD69 and CD103, which is a classical marker of tissue-resident memory T cell. When the other interesting marker they have is highly active, highly expressed CD38, so we call that an activate tissue-resident memory T cell. So what's most striking thing we saw is nearly all HBV-specific T cell isolated from acute-on-chronic liver failure, either targeting core polymerase or X. 90% of them are only have this phenotype, highly enriched in this activate tissue-resident memory phenotype. But while you look at the EBV-specific T cell isolated from the same liver, they do not have this phenotype. And this is also true from the same epitope isolated from the liver. And when you look at the same epitope, for example, HBV core 169 or HBV-X, isolated from the chronic liver failure patients, they also do not have this phenotype, suggests this phenotype is specific for acute on chronic liver failure in the liver. And if you try to quantify this, so here is one dot is one tetramer population. So you can see the HBV-specific T cell isolated from the liver of acute on chronic liver failure, nearly all of them are enriched in this activate tissue-resident phenotype, but not in chronic liver failure patient, and also in bicenter-specific T cell and the global CD8 T cells. And we did the same analysis using our Taiwanese cohort, but with a little bit more of cellular marker. And this time, again, here, this is the compile of all the CD8 T cell, and we found there's actually 3 different activate tissue-resident memory T cell, and they can be differentiated by the differential expression of either high or low CD38 or high or low of HLA-DR, both of the activation marker. And notably, they all express gwenzyme B and CXCR6. So if you just focus on these 3 different clusters, and we showed that the HBV-specific T cell isolated from the liver of acute on chronic liver failure patients, they highly enrich in these 3 different activate tissue-resident memory T cell. And then if you quantify them across the board, and then you can definitely see that in the liver, the black dot is the liver, the empty dot is PBMC. You can see then they're definitely enriched for this phenotype, only in the liver, but not in the blood. So we verify our staining using FACS, and this is an index sorting data. It showed that we can nicely detect those different populations of HBV-specific T cell in the liver. And what's interesting is that we found that they highly co-express CXCR6 and CD103. Previous Laura McKay and Thorsten Meppel showed that the upregulation of CXCR6 and CD103 is indicative of ongoing TCR engagement, so suggests those HBV-specific T cells being recently seeing their antigen and being keeping stimulated. And you can see the co-expression is only can observe in the HBV-specific T cells isolated from the liver of acute or chronic liver failure patients, but not the EBV-specific T cell isolated from the same liver of acute liver failure patient, and definitely not so much in the HBV-specific T cell isolated from the chronic liver failure patients. So we did the same analysis for the Singapore and Taiwanese cohort, and we see the similar stuff. And if you look at the Ki-67, which is indicative of ongoing cell proliferations and activation marker CD38, we see nearly all the Ki-67 positive cells express high level of CD38, but this phenomenon only observed in the HBV-specific T cell isolated from the liver of acute or chronic liver failure patients, and a little bit lower in the bystander-specific T cell, CD8 T cell, in this case is a flu. But we didn't see much of upregulations of the Ki-67 and CD38 in the HBV-specific T cell, CMV-specific T cell, in the liver of chronic liver failure patient, and definitely did not see that in the healthy liver donor's liver. And you can quantify this. You can, again, one dot here is one catchment population. So this is the HBV-specific T cell, bystander, global CDA, et cetera, et cetera. And the black dot is the liver cells. The empty dots are the PBMC. Again, you can see there. You can see most of the HBV-specific T cell in acute chronic liver failure are highly activate and have ongoing proliferations. So we look at the transcription factor, for example, T B and Yeomans, and we show that they have very strong Th1 program. And if you stimulate them with if you stimulate those liver cells with HBV peptide, expanding the core and polymer, you see that can produce interferon gamma and TNF alpha. So, what about B cells? So with the help of Antonio's group and Nina sitting down there, we used their antigen, HBV antigen probe to probe the HBV-specific B cell in the CD19 fractions and use flow to analyze them. So this is the representative plot showing you the staining quality of the antigen probe, nicely done by Lockmans. And again, you can see on the top is a liver sample, on the bottom is a PBMC, acute-on-chronic liver failure using the HBV core antigen probe, and here is the HBV-S antigen probe. So what's interesting is we only detect HBV core antigen specific B cells, and they are highly expanded in the liver of acute-on-chronic liver failure patients, diminish in the blood and not so much in chronic liver failure patients, also not so much in the healthy liver. And again, we did not see much of a response of the B cells targeting S antigen, which is similar to our data in T cells. And again, and then we try to quantify and identify the quality of those cells, meaning their phenotype. So if we can just focus on these two clusters on the top, this is all compiled for all memory B cells, including all the antigen-specific B cells. So this top two cluster is differentiated by their differential expression of CD40 and CD71, which is both are the activation marker of B cells. So this top cluster 11 is high level of CD40 and CD71, while the red one, cluster A, is have a lower level of CD40 and CD71. But this one is also very activate in expressing other activation marker. And the other difference between these two clusters is this cluster expresses IgM and this cluster expresses IgG. So you can look at the phenotype of those HBV-specific B cell targeting the core antigen. You can see them in the liver of acute chronic liver failure, they enrich in these two clusters, but not in the chronic liver failure patients, and definitely not in the global B cell populations. And there's some enrichment in the PBMC, but if you can quantify this, we found that cluster A are HBV core antigen specific. You can find them both in in the liver and blood of the liver isolated from acute-on-chronic liver failure patient or chronic liver failure patient. But cluster 11 seems to be only specific, particular for the liver of acute-on-chronic liver failure patients. So we think this is the relevant B-cell phenotype in this type of patients. So in overall, try to summarize the story, we found that those intrahepatic HBV core polymer-specific T cell and HBV core antigen-specific B cell were highly expanded in patients who have HBV-associated acute-on-chronic liver failure. And we try to characterize those T cell and B cells. So while those HBV-specific TRM are very highly activated, highly proliferative, very functional, expressing interferon gamma, TNF alpha, and granzyme B, and they have they co-express CXCRC, CD103, suggests they have a recent T cell engagement. And for the B cell, they have very activated, and we found there's two populations and one populations with IgM positive, but CD40 high, CD71 high B cell. They are probably relevant to the acute chronic liver failure in the liver. So why this is important, we think that we demonstrate the T cell and B cell activations in a very, although it's not very big, but in terms of these rare cases, it's a very nice cohort to show that there's a hepatic activation of T cell and B cells. And we show that maybe sometimes T cell is not beneficial for the disease outcome. And why this is important for clinical implications, so maybe, because in Taiwan, there's based on different healthcare guidelines, some patients will stop treatment. So maybe it's not so good to stop the treatment too early. And also in traditional clinic, doctor want to see the elevation of LT, for example, because traditionally it's linked to the immune response in the liver, so suggesting that T cell is killing the viruses. But perhaps it's not so good for this type of patient because this T cell, B cell may be harmful, so maybe it's not a bad idea to treat them steroid to kind of temporarily suppress the T cell, B cell response and get a longer window for waiting for liver transplantations. So that will be my last slide. So this is the current team. So I would like to particularly thank Sangi, who helped us to collect all the patient cohort in Singapore over 6-7 years. And the Taiwanese cohort was collected with the two different major hospitals in Taipei, Wei Chen Huang and Tong Hong Su, and also Antonio and his group, and Nina and Lockman, and all our funding agency. Thank you.
Yeah, great talk. Yeah. So now you're focusing on the HBV-specific TRM cell in this ACLF patient. But 2020, in my lab, we want to show that 6913 double positive cell are mainly HBV-specific, but 69 positive 103 negative cell are mainly the CMV, VV, flu, bystander T cell in the HBV-infected liver. But now, the bystander T cell are also less degree, but they also activated in the acute-on-chronic liver failure, right?
Yeah, some of them are very activated.
Yeah, for example, but there's no flu antigen. So what kind of cytokine activate those cells? So maybe you can identify some signature, cytokine signature from single-cell RNA-seq.
Yeah, we are doing it now. So yeah, but our major issue is the sample aliquot. Yeah, okay, so yeah. we are doing it. We try to sort the cell for single cell and see what's as you say, for example, you see there's any indications of the cytokine can bisynergically activate other flu, CMV, EBV-specific T cell. We do see a trend that there's more bisynergically-specific T cell in the acute-on-chronic liver failure. So you are right. Yeah.
Yeah, I guess the IL-15 or IL-18. So maybe you can find those.
Yeah, those are our top candidate.
Yeah. Thank you. Great talk.
Thank you.